Without further ado, advanced practice provider with Dr. Chen, Dr. Faso, and Dr. Patel. Welcome to each of you. Thank you so much for being here today. Let's find out a little bit more about you. So for our audience, Dr. Faso, PharmD, CPP, BCOP, clinical pharmacist practitioner in breast oncology at the North Carolina Cancer Hospital in Chapel Hill, North Carolina. And we are, in fact, in the lower level of that hospital now. All right. Received your PharmD degree from the University of Florida in 2003, completed residency at the Dartmouth Hitchcock Medical Center in 2004, and joined UNC as an oncology pharmacist in 2008 and has now been working with the UNC breast team since 2014. I think that's close to when I first met you when I joined. And Dr. Patel, PharmD, BCOP, clinical pharmacist practitioner at the UNC Medical Center, and went to pharmacy school at the UNC Eshelman School of Pharmacy. And isn't that a particularly well-rated school of pharmacy? I believe that's number one. And completed her first year of residency at the VCU Medical Center and hematology oncology training at UNC Medical Center, and currently practicing as a hematology clinical pharmacist at the UNC Medical Center in outpatient leukemia services, works on a multidisciplinary team to care for patients with acute and chronic leukemias. Dr. Patel, welcome. And Dr. Chen, PharmD, MS, clinical pharmacist practitioner at the University of North Carolina Medical Center, specializing in the care of patients with thoracic malignancies and sarcoma. Completed your graduate and pharmacy education at the University of Kentucky College of Pharmacy, and subsequently went on to complete his medical pharmacy residency at UNC Medical Center in 2020, and clinical interests center around precision medicine and dose optimization of targeted therapies. I want to thank you all so much for being here today. Dr. Faso, what's one thing we should know about you outside of your professional bio there?
Just that my hobby is baking.
Great.
And I especially love to bake cookies. So.
Great. Thank you so much. And Dr. Patel?
I love to read and actually have a book club. We do actually a little bit more than books. Sometimes we'll do podcasts and documentaries and stuff like that too.
That's great. And Dr. Chen?
Yeah, I really enjoy trying new restaurants. There's a wonderful, lots of new places in the Triangle area, so it's always fun to go to a different place every weekend and try something new.
Great. Thank you all so much. Our sample poll everywhere question, just to get things started. Oral oncolytics do not require any lab monitoring. True or false? I'm going to flash up our disclosures, and then let's take a look. We've already got folks answering. So it almost seems like the false answer to that question might somehow pertain to what we're going to be doing for the next little while here. Okay. And I'm assuming false is true?
That's correct. Yeah,
okay. Okay, great. All right, strategies for managing toxicities of oral oncolytics. I'll go ahead and turn it over to the three of you. Who will be starting?
I will be starting.
All right, perfect. I'll go ahead and just set that where you can get at those buttons.
Okay. So these are our objectives, and we hope by the end of this hour that you'll be able to describe various oral oncolytics that are utilized in the treatment of hematologic and solid tumor malignancies, as well as explain key considerations in the prescribing of oral oncolytics, and then develop a plan for toxicity management and monitoring for patients on oral oncolytics. So just to get us started, let's introduce oral oncolytics. Oral oncolytics are medications that are taken by mouth, and they can be cytotoxic, or they can target particular pathways, receptors that are involved in cancer. We have many oral oncolytics currently available for use, and we have more and more that are becoming available for use. And in fact, about 30% of new drugs that are in the pipeline are projected to be oral oncolytics. And these drugs have a wide range of uses as well as a wide range of mechanisms. Prescribing and managing oral oncolytics is complex. It involves multiple steps that often involves a multidisciplinary team. All of these steps are necessary so that we can ensure that patients have access to their medications and that they're taking it safely and effectively. So some of the steps that are involved in prescribing and managing oral oncolytics are just listed here. So for example, patient selection. It's important that we find a good fit for our patient when determining the best drug. And that can involve multiple factors. That can include even psychosocial issues. Choosing the right drug, choosing the right dose is obviously very important, and we're going to be talking more about that here in just a moment. Oral oncolytics are very expensive, so patients having access to these medications can be challenging. So it is very important that we do a thorough benefits investigation. Patients may need assistance for financial reasons in order to be able to afford the medications. Patient education is also a key part of this process. Patients need to understand how to take their medications, how to deal with side effects, how to contact the team when they have problems. And then finally, monitoring. We have to be able to get baseline monitoring that's necessary, as well as to do continual monitoring to make sure that patients are being safe and having effectiveness from their medications. So let's look at kind of the choosing the right drug and choosing the right dose. So there's multiple factors that we consider when making this decision. So for example, drug interactions need to be considered. Patient may already be on medications that requires the oral oncolytic to be dose increased or the dose reduced, or perhaps even the oral oncolytic might cause the other medications to have to be dose modified. Administration is going to be another factor that we will consider when making this decision. So some drugs just have complex administration instructions. They may have to be taken on an empty stomach or a full stomach, or have certain food requirements like a low-fat diet, or perhaps they're being taken multiple times a day. So these factors may need to be considered when deciding if this is the appropriate drug for a patient. Adherence is also going to be considered. We know that when patients take their medications appropriately, that they have better outcomes. So the more complex their regimen is, the more difficult it is for patients to be adherent to those regimens. Baseline monitoring is also going to be necessary when we're choosing the drug or dose, and that is because renal function and as well as liver function, as well as other tests may need to be considered on whether these drugs can be administered or if they need to be modified. And then finally, we're going to take into consideration the toxicity profile. Some patients may not be a candidate for a drug because of certain adverse effects, for example. So when safely prescribing oral oncolytics for our patients, first, we want to review certain characteristics upon initiation. So we want to look at the patient's diagnosis, and we also want to consider any comorbid conditions that they have. It is important to do that comprehensive medical history, as well as learning any drug allergies the patient may have. It's important to obtain height and weight. Some oral oncolytics, their dose is dependent on a patient's height and weight, for example. Assessing their functional or performance status at baseline will be important, and of course getting those baseline labs. But then there are other characteristics that should be monitored at each encounter after someone starts an oral oncolytic. So checking a patient's vital signs, checking if there's any changes in their weight, seeing if any new allergies have developed. It's important to assess if any toxicities have arisen since you last saw the patient. Doing that medication review is also important at each encounter, since patients may have been prescribed medications from other providers or have even started over-the-counter medications that could actually interact with their oral oncolytic. And then assessing their functional status, if there's any changes, and then of course reviewing the labs as appropriate for the oral oncolytic that they're taking. So what I'd like to do now is actually to go and talk about how we might choose a particular drug for a patient using a breast cancer case to do so. So first, before I jump into the case, let me just quickly review just breast cancer. So it is the most common non-skin related cancer in women in the United States, with an overall risk for a woman to develop breast cancer being 1 in 8 for women in the United States. It is the second leading cause of cancer-related deaths in women. And incident rates have been slightly increasing per year, but death rates have been declining. So when we look at systemic treatments for breast cancer, we have multiple modalities that we use, such as chemotherapy, hormone therapy, targeted therapies, and immunotherapies. On the right-hand side, I have the prevalence of different subtypes of breast cancer, and you can see that hormone receptor positive or estrogen receptor positive, progesterone receptor positive, and HER2 negative are the most common, being at 70%. So we're going to focus on the oral oncolytics that we use to treat breast cancer, and we have several different classes of drugs that we use to treat breast cancer. We have CDK4/6 inhibitors, PIK3CA inhibitors, we have HER2 receptor inhibitors, an anti-metabolite, as well as PARP inhibitors. So a lot of times when we're making these decisions, I had mentioned briefly that we would look at the toxicity profile of certain oral oncolytics. So just wanting to point out that certain oral oncolytics by class can have certain adverse effects, but also the drugs in each class may have a different kind of incidence of these adverse effects. So just to go briefly over what potential adverse effects each class might have. So for example, a CDK4/6 inhibitor, patients who have these drugs might have neutropenia, diarrhea, or hepatotoxicity. A PIK3CA inhibitor, these can commonly cause hyperglycemia or rash. HER2 receptor inhibitors, they can cause diarrhea or hepatotoxicity or cardiomyopathy. Our anti-metabolite adverse effects can include hand-foot syndrome or diarrhea. And then finally, our PARP inhibitors, anemia or nausea are potential side effects that need to be considered. So let's look at our case. So SL, she's a 65-year-old woman with a history of basal cell carcinoma. She was initially diagnosed with left breast cancer in 2013. It was ER positive, PR positive, HER2 negative. She had breast conserving surgery and radiation. She had a low-risk oncotype score at that time, so chemotherapy was not recommended. She initiated tamoxifen for adjuvant endocrine therapy with the plan to treat for 10 years. But in 2020, 7 years after initiation of tamoxifen, she presented to her oncologist with severe back pain. A workup revealed a vertebral fracture. CT also identified multiple pulmonary lesions, and a biopsy confirmed that she had ER positive, PR positive, HER2 negative metastatic breast cancer. So per the National Comprehensive Cancer Network guidelines, her oncologist wants to start the standard of care for first-line treatment of her hormone receptor positive, HER2 negative metastatic breast cancer. And the recommendation is to start an aromatase inhibitor, or AI, and a CDK4/6 inhibitor. So there are 3 CDK4/6 inhibitors available. So how does the oncologist choose which one? So I had mentioned earlier that toxicity profile can be a factor in how we make these decisions. So I have the 3 CDK4/6 inhibitors listed here. There's palbociclib, ribociclib, and abemaciclib. And I've indicated the potential adverse effects of each 3 of these. So you can look, for example, in the top line, neutropenia, palbociclib and ribociclib are more likely to cause this side effect, whereas abemaciclib is less so. So if neutropenia was a concern, you may want to choose abemaciclib over the other 2. However, abemaciclib is much more likely to cause diarrhea, and that might be a reason why you might consider palbociclib or ribociclib over abemaciclib. Other side effects such as hepatotoxicity, so ribociclib and abemaciclib are more likely to cause hepatotoxicity. So if someone has baseline liver impairment, then palbociclib would be a better choice in that case. And then finally, for ribociclib, it does have the potential to cause QTc prolongation. So if someone does already have baseline QTc prolongation, then ribociclib would not be a good choice. So another factor that would be considered in trying to choose the right agent is also efficacy. So for all 3 of these drugs, they are both FDA approved in the first-line setting with an aromatase inhibitor, and they're also approved in the second-line setting when given with fulvestrant. So let's focus on the top line here. It shows that all 3 of these can be given with an AI in metastatic breast cancer when given first line. Palbociclib and abemaciclib were both shown to have improvement in progression-free survival compared to patients who just received an AI alone. Ribociclib also found improvement in progression-free survival, but it also found an improvement in overall survival, which is not the case for the palbociclib and abemaciclib trials. So that could be another reason why we might choose ribociclib, just because of improved efficacy compared to the other two agents. So our patient SL, her baseline labs were normal. Her EKG showed that she did not have any QTc prolongation. In fact, her QTc was actually less than 450. And so because of that, and because of the efficacy associated with ribociclib, she was deemed to be a good candidate to start an AI of letrozole along with ribociclib. She was also given denosumab for bone metastases. So Bianca and Kevin, how do you select the best agents for your patients?
Yeah, thanks, Aimee. That's a really good question. This can be tough, as you already mentioned, especially when you have multiple agents within the same class. Efficacy is certainly a clear kind of first thing we can think about. When there's an efficacy difference, then oftentimes we will want to start with that agent. But it gets tough when all of our agents have similar efficacy, then we will have to look at things like side effects, toxicity, and put that together with our patients' comorbidities and the risk overall.
Mm-hmm. Yeah, that's really helpful, Bianca. Thank you. So all of those factors are going to be necessary in order to make that best decision. So let's go back to just with SL. So SL subsequently tolerated her first-line treatment with ribociclib, letrozole, and denosumab. She had mild neutropenia and manageable fatigue. But in March of 2023, a staging CT scan showed that she had increased pulmonary lesions and new osseous mets. A liquid biopsy demonstrated that she had a PIK3CA mutation. So per guidelines, her treatment was changed to fulvestrant with alpelisib. So the question is SL a good candidate for alpelisib? So first, looking at the indication, for alpelisib, it is for postmenopausal women with HR-positive, HER2-negative, advanced or metastatic breast cancer who have a PIK3CA mutation following progression on previous endocrine therapy. And just to refer back, our patient, she was on previous endocrine therapy with ribociclib and letrozole. She had a PIK3CA mutation, so she does meet the criteria for the FDA approval. Alpelisib does have a high risk for hyperglycemia, and studies have shown that there are certain factors that put a patient higher at risk, so that would make them a poorer candidate for the drug. And these higher risks include being over the age of 75, a fasting blood glucose of greater than 140, an HbA1c greater than 6.4, or a BMI greater than 25. Also, having a history of diabetes can also put someone more at risk, as well as other higher risk factors that I've listed here. So for our patient, for her baseline labs, her fasting blood glucose was 93 and an HbA1c of 5.8, and she had a BMI of 20. So those let us know that she's probably a good candidate for alpelisib. Her cholesterol was also within normal limits, and she didn't have any other contributing history. So because of that, we felt that she would be a good candidate for the drug. But we also want to make sure that we have her tolerate this medication as well as possible. And so there are things that we can do to help reduce the risk of some of these side effects. So for example, for hyperglycemia, we can actually start the anti-diabetic medication metformin 1 week prior to starting alpelisib, and that can actually reduce hyperglycemia. We can counsel her on a low carbohydrate diabetic diet, and we can tell her to take it in the morning after fasting with a low carbohydrate breakfast, as well as encouraging exercise. These all can reduce her risk of hyperglycemia. Counseling her on the symptoms of hyperglycemia would also be important. And then finally, because alpelisib can cause rash, and we want to reduce that risk as well, we can have her start cetirizine daily at the initiation of alpelisib to reduce that risk. So these are the things that we can do to improve her tolerance.
All right, and here's that first poll everywhere question. Which of the following factors can determine prescribing of an oral oncolytic? A, patient comorbidities. B, patient's baseline organ function. C, genetic mutations of the cancer. Or D, all of the above. And we'll give everyone 15 seconds or so to think about this and go ahead and respond with the answer you think is correct. All right, how are they doing? They all seem to have coalesced around all of the above.
Yeah, that's great. All of those are factors that we would use when prescribing oral oncolytics.
Great,
Great.
great. Thanks so much to the audience for jumping in there with those responses. And Dr. Patel, we'll turn it over to you.
Okay, great. Thanks, Aimee. All right, so with that, I will transition us straight into a completely different bucket of malignancies. So we'll go straight from solid tumor to hematologic malignancies, and I will be focusing on leukemias. So just to provide a very brief overview of leukemias in general, we have 4 main types of leukemia. We have 2 acute leukemias and 2 chronic leukemias. We have acute myeloid leukemia and acute lymphoblastic leukemia, so 1 myeloid and 1 lymphoid, and then similarly for chronic myeloid leukemia and then CLL. You can see on this figure here that they're actually all quite rare overall. Looking at the 5-year relative survival, acute leukemias can be deadly, so you can see more poor outcomes overall for our patients with acute leukemias, whereas CML and CLL are more so chronic disease states, so our patients can live for a very long time with these disease states. When we think about median age, these are typically much older patients with the exception of ALL, which is actually more common in pediatrics. In the orange boxes, what you can see is just a very brief kind of overview of some of our therapeutic targets. And just overall looking at each disease state, you can see for AML, we have BCL2. BCL2 is not a targetable mutation per se, but BCL2 is a gene, and the BCL2 family of proteins regulates apoptosis. So this is a therapeutic target that we use both in AML and CLL. We also have FLT3 and IDH. These are targetable mutations in ALL, so if our patients have these mutations, we're able to use those drugs. For ALL and CML, you see BCR-ABL there. So these disease states can be characterized actually by something called the Philadelphia chromosome, which is a translocation of chromosomes 9 and 22. This results in the BCR-ABL fusion oncogene, and we have tyrosine kinase inhibitors that can actually target this. CML is characterized by this. However, not all patients with ALL will be able to target this, but for some we can. For CLL, you see BCL2 again, and then you also see BTK, which is Bruton's tyrosine kinase, which is an important factor in B-cell receptor signaling, so also a therapeutic target. Just to put into perspective, like, how do we use these oral oncolytics in the leukemia space overall? Again, just breaking it down disease state to disease state. Starting with AML, we can use oral targeted therapy up front in combination with induction therapy depending on mutation profile. So for example, we can combine a FLT3 inhibitor with intensive induction chemotherapy. For patients that have a poor performance status or are unfit, we may also use azacitidine in combination with oral BCL2 inhibitor venetoclax. We can also use venetoclax and targeted therapies in the relapse and refractory setting as well. For patients with ALL, specifically if they have B-ALL with Philadelphia chromosome positive disease, then we will be able to use a BCR-ABL targeted tyrosine kinase inhibitor, and this would be standard of care therapy, typically in combination with multi-agent chemotherapy. For CML, we use BCR-ABL TKIs up front and at each relapse or if they have suboptimal responses. And then for CLL, we will typically use a BCL2 inhibitor venetoclax with an anti-CD20 monoclonal antibody or a BTK inhibitor up front, and then again, we'll just switch to the other one in the relapse setting. So overall, we are using oral oncolytics in leukemia very frequently. What I wanted to highlight here with this slide is that all of our drugs, they're common and they have very kind of specific monitoring. Like Aimee hinted at, a lot of drug-specific monitoring is going to be based off of the drug and the class that it falls into, how it works. So what you can see here are just some examples. BCL2 inhibitors, for example, are associated with myelosuppression and tumor lysis syndrome. We also have FLT3 and IDH inhibitors in AML that we use that are associated with differentiation syndrome and QTc prolongation. We have BCR-ABL TKIs, which I'll talk about in a little bit more detail later, but there are certain class toxicities that you can see here for many of those drugs. And then BTK inhibitors are associated with AFib and bleeding. And the reason why all of this is important is because it will also inform all of the monitoring that we need to do for these patients in order to keep them safe on these therapies. Some examples on the right highlight that also within each class of drugs, there can be particular differences. They can still have unique side effects, which are important to keep in mind. And again, those are important for monitoring parameters. So for example, if we start a patient on venetoclax, tumor lysis labs will be critical to their monitoring. Quizartinib is a FLT3 inhibitor that is associated with QTc prolongation, so this drug requires serial EKGs. And then you can see ponatinib is associated with cardiovascular toxicity and pancreatitis, so we need some strict baseline monitoring for that as well. So with that, I'll take us into a case. So JS is a 73-year-old male with a past medical history of COPD, GERD, and type 2 diabetes, found to have a new diagnosis of AML. He presents today to start standard of care therapy with azacitidine and venetoclax. You can see his med list there. What kind of lab monitoring does he need?
All right, and here we have another Poll Everywhere question. What kind of lab monitoring does he need? A, he will need an EKG at baseline. B, he will need an echocardiogram. C, he will need baseline labs for monitoring of the TLS. Or D, he will need baseline pancreatic enzymes. So please go ahead and take a few moments to think that over and then select the answer that you think is most appropriate. Right, Dr. Patel, folks seem to be settling on C. How are they doing?
Great, that's exactly right.
All right, we have a sharp audience as always.
Yep, so we definitely need baseline labs for monitoring of tumor lysis syndrome. And to go into a little bit more detail, really in practice what that looks like, the venetoclax monitoring in AML is intense, but you'll see a little less intense than what we do in CLL. For venetoclax in AML, it is a 3-day dose ramp up. So that is a preventative mechanism for tumor lysis, is that we ramp up to the target dose over a period of 3 days. In order to prevent tumor lysis, we also cytoreduce these patients so they have a white blood cell count less than 25. And then we encourage oral hydration prior to starting treatment, and then they'll receive IV hydration once they start treatment. They'll also be asked to start allopurinol to lower uric acid 3 days prior to treatment. This requires strict TLS monitoring, so they would need daily labs for the first 4 days of this regimen. The venetoclax is continuous, the azacitidine is for 7 days. And then after the first 4 days, they're not out of the window of tumor lysis, but the lab monitoring can be a lot less frequent, at least 2 times a week, once a week, depending on the patient. For CLL, it is much more intense. So what you can see here is that this is actually a 5-week dose ramp up. We start the venetoclax at 20 milligrams and move all the way up to 400 over a 5-week period. Before we do anything else, we will assess their tumor lysis risk. This is based off of their absolute lymphocyte count as well as their lymph node size. If they are actually deemed high risk, we will actually often complete week 1 and week 2, or the start of those weeks, in the hospital inpatient. But what you can see on this figure is a diagram of what it would look like outpatient. So for example, for weeks 1 and 2, they would get baseline labs, 6 to 8 hour labs, and then 24-hour labs. And so what that means is if they started on a Monday, they would come in, get baseline labs on Monday morning, and then stay for afternoon labs, and then come back Tuesday. And then, of course, baseline with each subsequent week as well. And then similarly to AML, these patients also will receive oral hydration at a minimum, sometimes IV hydration, and then also allopurinol 3 days prior. All right. So I will bring us into our next case and actually transition us over to CML. So JD is a 52-year-old male who was diagnosed with chronic phase CML in 2017. He has a past medical history of asthma and depression. He began therapy with imatinib 400 milligrams daily, which was dose reduced and then eventually stopped due to fatigue, fluid retention, and GI upset. He was then transitioned to dasatinib 100 milligrams daily, which he has responded well to, but unfortunately developed recurrent pleural effusions despite dose reductions in dasatinib. He is now planning to switch to nilotinib. What baseline labs does he need? So this is a very common question because we use all of these drugs so commonly in CML, is what baseline labs do they need? And this figure here is really for you all's reference. I've listed all of the tyrosine kinase inhibitors that we use in CML. And what you can see is their dosing, notable toxicities. What I want to point your attention to is the box, the green box on the right-hand side is class toxicities. So these are things we should pretty much always have on our radar. We should always be monitoring for at any time point. And then, of course, each drug has kind of its own unique toxicities or toxicities that are more commonly associated with it. And that's where some of the unique monitoring comes in. So, of course, we'll get CBCs and CMPs for all of these patients at baseline. But really, for some of these drugs, for example, nilotinib or ponatinib that have cardiovascular risk associated with them, we will get lipid panels. If associated with pancreatitis, we will get amylase and lipase. If associated with QTc prolongation, we'll be sure to get EKGs. And then, of course, periodic assessments of these two when relevant. So now I have a question for my colleagues. How do you all approach monitoring for targeted therapies?
Yeah, that's a great question. And I'm glad that you and Aimee both touched on this, the importance of both the baseline lab monitoring as well as the ongoing monitoring. So I do the same. I think when it comes to baseline, the importance there is that you want to make sure you have the appropriate organ function assessed in case you need any dose adjustments for liver or kidney dysfunction. Additionally, you want to make sure you have the appropriate baseline labs to do if there are specific risk factors such as cardiovascular risk factors, so knowing what their baseline QTc is, knowing what their baseline ejection fraction, because you may be able to identify patients at higher risk of certain toxicities, which may actually change your therapy selection, truthfully. And then lastly, again, knowing the baseline of certain toxicities such as hypertension, so knowing their baseline blood pressure is always good to know because it may warrant some therapeutic interventions, blood pressure lowering agents to start actually before they even start their oral oncolytic. The other piece of it is the ongoing monitoring. That's very important because, as we're hearing with Aimee and Bianca, and then I'll share as well too, is oftentimes our oral oncolytics are more toxic than our oral non-oncolytics. So a little bit of a misnomer is despite that they're an oral medication, they're well tolerated. Although that can be true in a lot of cases, they're not without their own side effects. So again, some of them can cause serious hepatotoxicity, lipid abnormalities, pancreatitis, and so really having our patients understanding that the monitoring is very important to track some of these things that they may actually not be symptomatic, and so really understanding and monitoring those labs is very important to keep an eye out to make sure our therapies are not causing these toxicities.
Great, thank you, Kevin. I think that's really helpful, and all of those actually perfectly highlight going into this next case here. So I'll end this segment with this case. JD has returned for follow-up 1 month after nilotinib. He feels well. He has had one medication change. He began quetiapine as an adjunct for mood. You can see on the screen here his labs. what you can see is that his blood counts are stable, CBC looks fine, and his CMP is notable for an elevated AST of 85, an elevated ALT of 130, and then his lipase is elevated at 212. He did have a baseline EKG, so not today, but at baseline it was done, and his QTCF is 444. So my question is, do we need another EKG today, and is any other action required? And really, this is a discussion. So the question of do we need another EKG today, this is can certainly be reasonable to get an EKG today. We might want to because he was started on quetiapine, which is a potential QTC prolonging agent. However, you could argue his QTCF at baseline was perfectly normal. And so there's no concrete actually right or wrong answer. I would recommend getting one if we have a patient in clinic and we know that he's been on this new drug. It doesn't hurt to get one, and then we have a new baseline on both therapies. However, this is something that we should be assessing at all times when we should be getting EKGs if patients have medication changes. Is any other action required? So you all will have noticed that the patient is experiencing transaminitis and an elevated lipase, but he feels well. So with him feeling well and the lipase of 212, it's actually not considered a grade 3 toxicity. Same with his liver enzymes. They're elevated, but it's not a grade 3 toxicity. So if you were going to look at the nilotinib package insert, for example, you would see that you actually don't have to do anything different at this point. But I think this sets up Kevin's portion perfectly because, of course, if the patient was having symptoms or more significant toxicities, we certainly would go a step further and make some adjustments. The only thing I would recommend here is not waiting another 3 months to bring the patient back. We'd probably want to bring him up sooner than a month. All right, and then with that, I will transition to Kevin.
All right. I don't have any fun emojis for my section, so I apologize for the tease there. But I will talk a little bit about lung cancer. And so for my section, like Bianca alluded to, we'll focus a lot about the therapeutic management of these side effects that may happen with our oral oncolytics. And so first off, just a little bit of background on lung cancer. So it's a very common cancer. It's the third most leading common cause of cancer in the United States behind prostate and breast cancer. However, it is the most deadly cancer, so it still remains the leading cause of cancer-related mortality. Interestingly, we always historically associated with this as a disease of those who have tobacco exposure. However, the most recent statistics show that about 1 in 6 patients who die of lung cancer actually have very minimal to no smoking history. This is particularly important because these patients oftentimes are enriched for these driver mutations. So these are the EGFR, ALK, ROS1, RET, things like that. There's other histological features that may increase your risk, such as adenocarcinoma, younger age. However, the thing I want to point towards on the graph on the right, though, is that in most patients, and so over 50% of patients, we actually can find the known driver of what's causing their lung cancer. And this is irrespective of smoking history, so highlighting the importance of testing for appropriate patients. Mutations such as KRAS and BRAF actually happen just as frequently, if not more frequently, in those patients who have a smoking history. And really the importance of testing is also because we have wonderful targeted therapies for the treatment of lung cancer depending on your specific genetic alteration. And so with our targeted therapies, they're more efficacious than chemotherapy, and with some few exceptions, generally are less toxic as well than traditional chemotherapy. And if they're an oral agent, they certainly are more convenient for patients. You don't have to come to our infusion center, get labs, sit in a chair for several hours, and get the IV. You can actually just take this in the convenience of your own home. Now, lung cancer has been serving as really the prototype of targeted therapy development in all of oncology. It wasn't that long ago. We only really had 2 targeted therapy approved, so erlotinib for EGFR mutations and crizotinib for ALK rearrangements. So as you see here on this slide, in 2024, we now have 28 different biologic entities that target 9 distinct genetic alterations in lung cancer, which is phenomenal. There's more to come in the future. But that also means when it comes to therapeutic management, it can be hard to keep up with all the different therapies that are coming out. And so for the therapeutic management part, we could spend hours just talking about each individual drug and all the different toxicities. What I thought would be more helpful is actually talking about just ways to think about these therapies. How do you conceptualize toxicities, and how do you manage them in general? The first one, just like Aimee mentioned, there are some therapies that have class effects. And so for EGFR, this is one of our earlier drugs that we've had in lung cancer. And so these are, as the E in EGFR stands for, epidermal, unsurprisingly cause a lot of cutaneous toxicities. So acneiform rash, diarrhea, mucositis, paronychia. HER2, which we certainly have some drugs that target HER2, they can cause cardiomyopathy. Other medications that we're having that are newer targets, such as MET, can cause very significant peripheral edema. And lastly, the TRK inhibitors, or anything with the TRK activity, can cause these CNS toxicities. And so knowing what targets your drugs hit can actually help you understand what side effects may come. And so in addition, EGFR inhibitors such as osimertinib, they certainly can cause all these cutaneous toxicities. It also has off-target HER2 effects as well. And so because of that, it can cause reversible cardiomyopathy. Similarly, brigatinib, although very helpful as an ALK inhibitor, it also does have EGFR activity. And so one of the notable side effects of brigatinib is actually a rash. Crizotinib, one of our earliest inhibitors, not only do we know that it's efficacious for ALK, we also know that it has good efficacy against ROS1 and MET, but because of some of the MET side effects, it can cause some profound peripheral edema. And so again, knowing what targets that your oral oncolytic hits, not just the intended target, but some of the off-target, helps you understand the different side effects. Lastly, I'll point towards the examples of selpercatinib and pralsetinib. So these are two of our newer RET inhibitors. And what's interesting is there are certain targeted classes of meds that don't really have known targeted side effects. So those being RET, ROS1, ALK, we don't really have a class effect of those therapies. However, due to some of the sequence homology, so for example, RET with the VEGF kinase domain, both of these RET inhibitors actually have VEGF activity. So a lot of their side effects actually come from the VEGF activity, not the RET activity. So they can cause wound healing impairments, hypertension, cardiotoxicity, things like that. And like I said, when it comes to adverse events management, this is, again, a general framework. We'll dive a little deeper here in a little bit. But generally speaking, we talk about mild toxicities, so grade 1 toxicities. We can generally support patients through this. And so we can continue the targeted therapy and provide some supportive care. So if we're using EGFR inhibitors as the example, this is when we would start our topical steroids and topical clindamycin. If they're having worsening side effects, so grade 2, so moderate severity, you can consider holding the targeted therapy. Really, this is oftentimes driven by patient's symptom burden. And so if it's very symptomatic, this is a time that you may want to hold the therapy. If it's not super symptomatic, you may consider continuing it. But it is always important to increase your supportive care. So if we're, again, using the EGFR example here, this is where I would start adding another agent. So for example, doxycycline to help reduce that rash. And then when it comes to grade 3 or 4, so serious potential life-threatening side effects, you should always hold the targeted therapy to help speed up that symptom recovery because you don't want to keep that offending agent if it's causing a serious or life-threatening side effect. You want to obviously maximize your supportive care. And so for this case, these are the times where I start thinking of systemic steroids, so short prednisone burst. And when you're thinking about restarting it, this is also the time to think about restarting it at a reduced dose to, again, lower that risk of a potential serious life-threatening side effect. Now, again, those are some general guidance, but I thought it'd be helpful to use a specific case to talk a little bit more about specific medications. And so this is the case of DM, who's a 49-year-old young lady who's a never smoker. She's found to have metastatic lung cancer and have a EML4 ALK fusion. She was started on first-line alectinib and had good disease control for a few years, although after about 4 years, she's had worsening abdominal pain and restaging scans actually showed a new liver lesion. As we oftentimes do in lung cancer, we try to find the resistance mutations to our targeted therapies. And so we did another NGS panel, and we actually found an ALK mutation that conferred resistance to her alectinib, and that's the G1202R. And because of that, your medical oncologist wants to start second-line lorlatinib. And so what are some appropriate side effects to counsel this patient on? And so though I mentioned that there are some general class effects that you may see with different therapies, it's always important, especially as new therapies are coming onto the market, to know exactly what side effects the medications can cause, because there may be some side effects that you may not expect. So specifically for lorlatinib, there's some unique side effects which are not super common in my world with our lung cancer targeted therapies. And so lorlatinib can cause quite a bit of hyperlipidemia. Almost everyone has it. Edema can be a very significant side effect. Despite not having met activity, it still can cause peripheral edema. It can also cause weight gain, which can be very impactful, particularly as people are on therapy for longer. And because of its good CNS penetration, it can also cause some of these CNS toxicities, some neuropathy, cognitive, and mood disorders. Again, looking through the package insert is important because not only are there common side effects, there may be serious side effects that can happen. So again, those including AV node block, serious hypertension and hyperglycemia, as well as pneumonitis. And so again, making sure that you're aware of all these different therapies, counseling your patients appropriately, as well as monitoring as they remain on therapy. This is just a quick iconograph pulled from one of the papers of lorlatinib side effects. And what I wanted to illustrate with this is actually showing the different onset of different side effects, because although you have different side effects that may happen from a targeted therapy, they may not all come on at once. And so hyperlipidemia, this is one that comes on pretty early on. However, in contrast, you see that edema and neuropathy, they often kind of take a little bit longer to come on. On the very bottom, you see the cognitive effects, and you see that those can come on really at any time, early on, month 1, 2, or 3, as well as kind of later on, month 6 or later. And lastly, I want to point towards weight gain, because there are some toxicities that may actually progressively worsen the longer you're on therapy. Weight gain is actually one of those. And so you see the median duration of the weight gain is actually 778 days. And so that's really over 2 years. And so again, as people are on therapies for longer, that's a great thing, but some side effects may actually come on the longer you are on treatment. Now, like I said, a lot of what I'm going to talk about is actually focused on the therapeutic management. And so talking about these specific side effects that lorlatinib can cause, luckily hyperlipidemia, we've had decades of knowledge in the primary care world on how to manage this side effect, and it's no different. So statins, if refractory to statins, adding ezetimibe or fibrates or fish oils, as well as PCSK9 inhibitors, these are all adjunctive therapies that may help. When it comes to the specific statins, there is some considerations for rosuvastatin, pitavastatin, or pravastatin due to just some drug-drug interactions with the lorlatinib itself. And then when it comes to holding therapy, again, if there is a risk of serious, significant hyperlipidemia, so specifically at levels where patients may be at risk of acute pancreatitis, this is when you may need to hold therapy. When it comes to edema, again, very similar to edema management in other regards. And so if you're having peripheral edema, doing lifestyle modifications, compression stockings, reducing salt intake, elevation, these are all appropriate, as well as trialing diuretics. However, we'll talk a little bit more later about this too, but depending on the severity of edema and if it's refractory to some of these other therapies, you may need to consider dose reduction. Weight gain, this is actually one of the harder things to manage, I'll be honest. As we're having newer data for lorlatinib, I suspect it's going to be used more and more in the frontline use of rearranged non-small cell lung cancer, especially after this year's ASCO meeting. Weight gain is one of these things that we're seeing more prevalent in patients that are on these therapies for many, many years. The other problem is there's not really good, robust treatment. And so again, the general guidance is diet, exercise, food intake, nutrition referral. But admittedly, that only goes so far. And so that can be a challenging side effect to manage. And lastly, peripheral neuropathy, again, very similar to how we would manage in other disease states, such as diabetes-induced or chemotherapy-induced peripheral neuropathy. So again, gabapentinoids, duloxetine, TCAs, these are all appropriate therapies. But again, you may need dose holds and dose reductions. Lastly, I want to focus on cognitive side effects, because these cognitive side effects can actually be pretty impactful for our patients. And so just to talk a little bit about cognitive side effects, I want to bring back our case of DM, who has been on lorlatinib for about 2 months now. Unsurprisingly, she's been started on rosuvastatin for hyperlipidemia and duloxetine for peripheral neuropathy. She comes back to her clinic with her husband for routine check-in, and she actually tells you that she's been having new difficulty remembering things. She's a new mother of some newborns, and now, she would have never forgotten this before starting med, but now about once a week, she's forgetting to feed her new babies. It's causing her a lot of distress. What's interesting is actually, after your visit, as you're about to go and touch base with your med onc, her husband actually pulls you aside and says that, her personality has also changed. She's now become very irritable. She's very impatient. She has a very short fuse. This isn't like her at all. She was the sweetest woman, and this was completely uncharacteristic. Now, even minor inconveniences, such as a little bit of traffic, she's now getting road rage, right? And so this is just really bothersome to them. And so the question here is, so what grade of cognitive and mood effects is your patient experiencing? And just like Bianca had mentioned, this is an open-ended question because really this is a very subjective grading. If you look at the CTCA grading, really it relies on how impactful it is on your patient. And specifically the language actually is around their activities of daily living. Now, how do you quantify that, right? Do you consider commuting an activity of daily living? Or do you consider that showering and making food for yourself? What about feeding your newborn, right? These can be very subjective, but again, talking to your patients, understanding the impact it has on their life will help you better understand what to do. Now, again, unfortunately, when it comes to what to do, we don't really have good therapies to improve memory changes or even these mood changes. And so what I wanted to actually talk about is about dose reductions, which is commonly what we'll do in our clinic if patients are having these cognitive effects. But I do want to open to Bianca and Aimee to talk about how do you all approach dose reductions for different toxicities in your clinic?
Yeah, Kevin, we approach it differently depending on the oral oncolytic. So, for example, looking at my case for our patient SL when on ribociclib, there's good data with ribociclib that shows that if you decrease the dose, you actually can continue to get the same benefit. But with alpelisib, for example, what she was on second line, the data actually shows that when you decrease the dose, you can actually decrease the benefit. So for that particular case, we would want to do as much supportive care as possible before having to reduce her dose. So it really depends on the oral oncolytic that we use.
Yeah, that's wonderful. And I'm actually glad you brought that up because when it comes to data, you're absolutely right. We actually don't do a great job as an oncology field of historically studying these targeted therapies. When these therapies were initially developed, we used the old paradigm of this 3x3 dose escalation because the presumption here is that more is more, right? With cytotoxic chemotherapy, the more you give, the more efficacious that it is. But with our targeted therapy, that's not quite true. We certainly have plenty of examples that may not hold true, and lorlatinib is no different. And so this is actually one of the PFS curves pulled out from the Crown update, like I mentioned, from ASCO of this year. And this is specifically looking at patients with dose reductions in the first 16 weeks of starting treatment, and that's in the solid line, compared to those who did not have a dose reduction in the dotted line below. And I will caveat, this is very small numbers, so you see only 18 patients actually needed a dose reduction. But interestingly, when you actually look at the PFS here, those with actually dose reduction, that line is sitting on the top. I don't think the numbers are large enough to have any statistical difference here, but it certainly doesn't point towards less efficacy, just like you alluded to, Aimee. And so again, it does depend on the medication, and it does depend on the specific toxicity. But again, dose reduction should be something to consider, particularly if your patients are having very challenging side effects from their therapies. All right, and I'm going to jump off to the last audience response question.
All right, and that is, which one of the following matches is the appropriate targeted therapy and indication? A, oh boy, I may have you all jump in and help me with the pronunciation on a few of these. Would somebody like to take these?
Sure. A, venetoclax with CML. B is palbociclib with PIK3CA mutant breast cancer. C, tucatinib with HER2 mutant breast cancer. And D, lorlatinib with EGFR mutant non-small cell lung cancer.
Great. And while folks are thinking about that, based on my pronunciation, you can pick which of the four in this lineup is not a pharmacist. I think you won't have any trouble with that. All right, take just a few more seconds. This is our last Poll Everywhere question before we open things up so that our audience may ask questions. So as soon as we finalize the answer to this question, I'll go ahead and switch things over and you can start sharing your questions while our presenters are finishing up the presentation. All right, which one is the answer that you were hoping for?
Yeah, I think this is right. I think most people got this right. So tucatinib, this is a HER2 directed therapy, which is very helpful in breast cancer. All right, just to wrap us off, so with our conclusions, we just want to share that it's always important to consider many different patient-specific as well as disease-specific characteristics whenever you're selecting the appropriate oral oncolytic for their treatment. Again, just like Aimee had highlighted, choosing an agent within this class, you want to evaluate not just its efficacy, but as well as its dosing and administration, the side effects, as well as your patient characteristics, which they may or may not be more vulnerable to specific side effects, and that includes some of the comorbidities such as cardiovascular and diabetes. Baseline and subsequent monitoring is very critical to maintaining patient profile, safety profile on an oral oncolytic. And then when it comes to the therapeutic management, again, there's all these different strategies for managing, including different supportive care strategies and non-pharmacologic as well as pharmacologic strategies. However, dose reduction should always be in your pocket as well, depending on the severity of the toxicity.
All right, and we have the questions open here, so we'll be waiting for your questions from the audience. We do have a few minutes to take those questions. And while we're waiting for those to come in, let me ask for each of you, over the next few years, you've each spoken, Dr. Faso talking about breast cancer, Dr. Patel talking about hematology, Dr. Chen talking about thoracic medicine and precision medicine. From your perspective, what sorts of changes are you hoping for over the next few years? What do you see on the cusp of emergence right now? Dr. Faso?
Yeah, I think as we move forward, we're going to see new classes of drugs, and that's going to mean, new novel side effects and new novel management that we're going to have to be able to learn and consider. And I think also regimens are getting more complex as well.
Okay.
So having a multidisciplinary team is really necessary to care for patients on these regimens.
Great. Thank you so much. And Dr. Patel?
Yeah, I think similarly, our regimens are just getting more complex, definitely anticipating more oral oncolytics and management of side effects for oral oncolytics. Also, when we think about some of our agents, we think about mutations that actually develop resistance to these drugs, and sequencing of therapeutics. It gets more and more complicated when things get moved from the relapse setting to frontline setting, and it just becomes unclear how to sequence drugs. So those are things we're hoping for more information on.
All right. Thank you. And Dr. Chen?
Yeah, I completely agree with Aimee and Bianca, and I think one of the exciting new classes of medication that Aimee had mentioned, at least in lung cancer world, is these antibody-drug conjugates. I think they're interesting in that they're taking these historic, very toxic cytotoxics and actually using a little bit more of a smart design. So it's a little bit hybrid, right? So rather than the traditional pure targeted therapy, it is targeting the cancer cells but still relying on a cytotoxic. I think to that vein, that also does come with its own toxicities, but there's other, novel ways to target better the lung cancer specifically. So, for example, like radioligands, so not just antibody drug conjugates, but antibody radioligand conjugates. I know in prostate cancer, they've had a recent approval for that with, I think it's PCMA. So again, looking at that, targeting that surface protein for the prostate cancer and then attaching a radioligand, which comes with its own toxicities. I'm excited to hopefully have some of these options for lung cancer as well.
Great. Thank you so much. And we're still waiting for questions to come in. We've got just another minute or so to take those if anyone would like to submit them. While we're waiting, what about cost? So it might be tempting to think, gosh, the IV medications, all that's involved with that and the cost. Are oral oncolytics less expensive? Do you see the range of costs that might impact decision making as far as prescribing?
Yeah, oral oncolytics are generally very expensive, and that can be a huge challenge for our patients in order for them to be able to get the medications. I know that all of us have to work and help patients with that challenge because financial toxicity is a huge consideration.
Sure,
Yes.
sure. So overall, they're more expensive than the IV chemotherapy?
It can be. There can be more out-of-pocket costs for patients. All of that depends on patients' insurance and what kind of coverage they have, but it can be a complex system to try to figure out for patients.
Understood. All right. Dr. Patel, Dr. Chen, anything you'd like to add?
I was just going to say, yeah, no, I'm actually glad you brought that question up because I think it's outside of just pure cost, right? I think it has to do with the complexities of the the billing of our therapies. I think you're absolutely right. When you think about these oral targeted therapies, they're certainly more expensive than often our traditional cytotoxics, but they may not necessarily be more expensive than our immunotherapy or some of the other therapies that we give that are intravenous, but I think it also highlights some of the discrepancy here in the medical versus the pharmacy billing and kind of the patient responsibility and that financial toxicity that actually reaches them with the difference of an oral therapy. So with the pharmacy billing, this is oftentimes why we get looped into this, is because patients are oftentimes responsible for more of that cost of their therapy compared to an intravenous or any therapy given in clinic, right? And so I think that's a big area of need that we have as an oncology field of how do we better bridge that difference and that gap and be able to offer these expensive therapies for our patients regardless if they're an oral therapy or an IV-based therapy.
Thank you so much, Dr. Chen. Dr. Patel, anything you'd like to add?
I think that we covered it. I think that luckily we are a well-resourced team and that we definitely make sure that our patients are in good hands. We'll do everything that we can to support them from a cost perspective and try to make it not the actual thing that limits them for that treatment, but to Kevin's point, it's not just about their costs, but there's a lot more to it. Overall, long-term financial toxicity, when you compare to the benefit they may be getting from it, the side effects they may be having, we really do also think about patient quality of life, big picture.
Thank you so much. Well, I want to thank each of you, and I want to applaud all that you do. It's incredibly important work, and we are very thankful and very fortunate to have you all here today. Just a few things to wrap up. So we want to say thank you to the state of North Carolina for the support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. Thank you to the people of North Carolina. Thank you to Venny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, and Barbara Walsh for all the work they all do for each and every one of these lectures. There's a lot that goes into these.